So we had wonderful times, and when it was really nice to catch up with him recently in a conference. So Salvatore is a brilliant gastroenterologist and endoscopist. He focuses on endobariatrics, and he's at the Gemini Isla Hospital, which is in Rome, and he works with a very renowned gastroenterologist, Dr. Costomagna. And thank you, Salvatore, for joining in, and we'd love to hear from you. Thank you. And next we have Dr. Raju Mahule. Raju is a young budding gastroenterologist. He's currently started his gastroenterology practice in Gondia, and he's the director of Mahule Gastro and Liver Center, so in Gondia. So Raju, welcome. Thank you for joining, Raju. Okay. So I think I will let the chairpersons take over the proceedings from here. Thank you.
Good evening, everyone. So we'll start our first presentation today. First presentation is unusual esophageal ulcers, 4 cases by Dr. Shrikant Mukhewar. Over to you, sir.
Yeah. Thank you, chairpersons. In fact, recently it has happened that we encountered few of the interesting esophageal ulcers. So we thought that we should discuss with you all about these cases. I'm going to take time equivalent to 2 cases. So please allow me to do that with your permission. So this is a 60-year-old female who had presented very recently on 25th of April, and she had presented with sudden onset of dysphagia for the last 3 days. There was no previous history of heartburn, regurgitation. There was no history of chest pain, no history of bleeding, fever. There was no history of corrosive or drugs, no history of neurological symptoms, and no history of nasal regurgitation. So the endoscopy done revealed that she had extensive ulcerated mucosa. The mucosal pattern was lost, and you had deep ulcerations, what you can see here, and with inflamed mucosa, and that was involving the upper middle 1/3 of the esophagus. A suspicious of hiatus hernia was there. Because of the instrument could go inside, the endoscope could go inside the stomach. Overall, the impression was that of a chemical esophagitis. But on repeated asking, we had an interview with her that whether she was taking drugs, and there was no history of any corrosive or drug intake. So, so the histopathology revealed only necroinflammation without any specific etiology. There were no granuloma, no fungal hyphae. So diagnosis tentatively was put as severe reflux esophagitis. She was put on double dose of PPI considering the severity of esophagitis, and came after 4 days to collect the histopathology report. When interrogated again, and she was, I said, just show me the file, and then she was showing that she was taking thyroxine for hypothyroidism. She had a fracture after a trivial trauma and diagnosed to have osteopenia. She was taking calcium, vitamin D, and osteophos, alendrolic acid. So on asking leading questions, do you consume pills without water? She was saying yes. Do you consume it just before going to bed? She said yes. And asked to get her motility study. She was from a very affluent family. Her sister-in-law is also a doctor and researcher, pediatrician. In fact, when we talked to her first time and asked Archana, is she taking any medicines? She says, "Well, she denied taking any medicines." So we asked her for motility studies, but she was not willing. So ultimately the diagnosis was that she is having a drug-induced esophageal damage. Suspect clinically when you have sudden onset of symptoms, retrosternal chest pain, you have a dysphagia in 30% of patients and odynophagia of 40% of patients. Absence of history of heartburn regurgitation, presence of sudden onset of dysphagia together with drugs and odynophagia clinches a diagnosis of chemical or drug-induced esophagitis. The various factors are there. Acidic pH in the esophagus as done by doxycycline, ferrous sulfate, hyperosmolar by potassium chloride. Gelatin capsule can get stuck and dissolve, disintegrate in the esophagus, breaking mucosal barriers like aspirin and NSAIDs. They can cause the mucosal barrier and cause ulcers. And ultimately, the size of capsule and tablet is very important. Various drugs have been implicated. Doxycycline is the most notorious in our practice. And clindamycin, trimethoprim sulfa. I am sure many of the gastroenterologists here have seen doxycycline-induced ulcers. ASA, indomethacin, ibuprofen, ferrous sulfate, potassium, ascorbic acid, antiretroviral drugs. Alendronate is also a notorious agent. The instructions which are given while consuming alendronate is you have to consume it with 200 ml of water. And if you don't consume it with less amount of water, it is known to get disintegrated. And our patient did not have that. So in a survey, one of the studies, patients consuming medicine without water was 40%, just before sleep was 40%, and the recumbent position allows the capsule to get stuck in the esophagus. Geriatric population is supposed to be very prone for all these. Low saliva, altered anatomy because of cardiac problems, motility disorder, esophagus pressing on the aorta pressing on the esophagus, and potassium, quinidine are the frequent medicines which are given to this population, and they are most of the times recumbent. That leads to chemical esophagitis. So our patient has alendronate-induced esophageal damage. To be 100% sure, we should have a re-challenge, which are not done in our patient, but the literature is sufficient to tell you that this is a known drug to be responsible for it. So we come to the second patient, and you can see very interesting story of this patient. A short history within 5 days that this patient also had come. He had a short history of fever of 8 days, followed by extensive esophageal ulcers, dysphagia, mild dyspnea. Clinical examination, if you see carefully, you will find that this patient had oral ulcers, which are like punched out circular circumscribed ulcer. And on the lip, if you see on the upper aspect, I don't know, ये तो चल नहीं रहा है. If you see here, you can see one small vesicle type thing. So clinical diagnosis was that of herpes simplex, herpes simplex. Investigations revealed hemoglobin was okay. He had low platelets. The metabolic functions were normal. Febrile illness investigations were negative. There were no abnormal cells. and the endoscopy was done, which revealed that he had ulcerations throughout the esophagus, which were like punched out ulcers, and in the middle and lower esophagus, they were more. Now, majority of the times we take a biopsy and send the sample for the tissue PCR. So as you can see here, the ulcerations are there, superficial ulcers, little more in the middle esophagus. We taken the biopsy and send it for histopathology. The biopsy had revealed necroinflammation, no granuloma, and no changes to suggest HSV, no fungus, and no malignancy. The HSV PCR, which came after a period of 5 days because it takes time, but on the clinical grounds, you have to start treatment. That was also negative. In the meantime, the patient was put on acyclovir 800 milligram 5 times a day for 5 days. PPI was done. On the 4th day, his patient's ulcers disappeared and had response. So possibly, we are not sure that whether this patient has HSV esophagitis, but more or less sure because of the oral lesions. अरे एकदम ही अंधेरा हो गया. So we come to the third patient. अच्छा. So we come to the third patient, who was a 14-year-old girl who is ICH, diagnosed on ART, vertical transmission. Mother and father unfortunately succumbed to HIV. She had dysphagia for 3 months and was referred to her with endoscopy. CD4 count was 200. The endoscopy done, can see here the lower end of the esophagus. You can see a very pinpoint narrowing, which is very, and in the upper middle esophagus, you can see deep ulcerations, and which are like deep circumscribed ulcers from which we have taken a biopsy. So these ulcers were looking like candida ulcers, which are more common, but we have taken PCR for both HSV and CMV. See, the biopsy again shows a hyperplastic mucosa, muscle abundance, lymphocytic infiltrates, not significant eosinophils to call it as eosinophilic, and chronic inflammation. The pathology HSV PCR was positive and CMV PCR was also positive, and the patient was already on the HIV treatment in the form of dolutegravir, emtricitabine and TAF, and treated with acyclovir and ganciclovir for both after we received the reports. I will call upon Prajakta to discuss the differential of histopathology. But before that, I'll just tell you that Prajakta, you can come. Mic is there. I must introduce Prajakta. Prajakta Sathone is a histopathologist who has joined MIDAS. She is one of the most, I should say, very competitive, comprehensive, and very perfect histopathologists. Up till now, we are so happy with her performance that I compliment her for that.
Thank you so much, sir, for your kind words. We had a differential of HSV versus CMV, and in this case, both the viral PCRs were positive. Apparently, in the particular case, we did not find any cytopathic effect on the histopathology, which could be due to the focal lesions or early lesions. But the typical histopathological features in HSV are the 3 M's, that is the nuclear molding, margination of nuclear chromatin, as we can see in the picture, and multinucleation. So these are the typical viral cytopathic effects. And
इकडे पाहत दाखव. हा, तिथे. नाही, लाल याच्यावर.
okay. So in this picture, this is the HSV cytopathic effects. This is the multinucleation that we can see. Then there is nuclear molding and the nuclear margination of the chromatin, which we can see. Versus in the cytomegaly virus cytopathic effects, the most common is the nucleomegaly. Here in HSV, we see the changes only in the epithelial cells, versus in cytomegalovirus, it's in the epithelial cells as well as in the mesenchymal cells, that is fibroblast and endothelial cells as well. So here we can see the endothelial cells are also showing the nucleomegaly, and this is the nucleomegaly of a fibroblast. This is the nucleomegaly of the epithelial cells surrounded by the granulation tissue.
All appearance.
Sorry.
All eye.
Yes. The inclusions, intranuclear inclusions are seen in both the cases. Here we call the Cowdery type A inclusions, which are acidophilic, whereas in cytomegalovirus, it's a basophilic intranuclear inclusions, which is typically the Ulcer inclusion. However, we cannot appreciate here, but they are typically very Ulcer appearance. And the diagnosis, after the presumptive diagnosis of HSV and CMV on endoscopy, we can confirm the diagnosis by histopathology and IHC, which are the gold standard. But the sensitivity of histopathology is around 65 to 70%. Some can be missed, and which can be confirmed by PCR techniques. Thank you.
Thank you. Thank you. Rajik. Yeah. So basically, HSV has superficial ulcers, CMV has deep ulcers. HSV well circumscribed. The CMV has serpiginous, larger ulcers, and the histology is already discussed. Sometimes it's difficult to differentiate. On the left-hand side, you can see HSV ulcers, and on the right-hand side, you can see the CMV deep ulcers, linear ulcers. This is the 4th patient, 61-year-old female who has been following us with us for the last many years. Diabetic, hypertensive, dysphagia since last 6 years. Endoscopy earlier was diagnosed as post-Crippard web and stricture. Biopsies were negative, no peripheral eosinophilia. She underwent 2 sessions of dilatation outside and asymptomatic, and then dysphagia recurred. So she came to MIDAS in 2020, where we did an endoscopy. As you can see here, it's you can see the furrowing of esophagus, circumscribed narrowing of the esophagus, easy friability even after putting the endoscope. You can see that the friability was very easy, as if the esophagus is circumscribedly narrowed. So after this, the histopathology was done. We showed evidence of eosinophilic esophagitis when that time the diagnosis, which was not done for 2 years, was done, and she was put on steroid PPI elimination diet, underwent 4 sessions of dilatation from June 20 to March 24. Subsequently, this time she had come for dilatation again on 3rd of March, when we dilated up to 14 mm. So you can see here a significantly narrowed esophagus. and a very friable mucosa. It's always very challenging to dilate the esophagus in a patient with eosinophilic esophagitis. One has to be very careful because chances of perforation are very high. And after the dilatation, post-procedure patient was kept nil by mouth, hemodynamically stable. Complaints of right-sided chest pain managed by analgesics. We thought that she could have perforated, and then the barium was advised, which revealed the leak from the esophagus as well as the effusion on the side. Endoscopy done revealed a large rent in the lower end of the esophagus, which I am not sure whether it is possible to show you, but I'll try and show you. I don't know whether it will be. It's already gone, no? So there was a big rent in the esophagus. So here it is. Yeah, it's a big rent there. So then we decided to put the patient ICD, the infection, I mean, it was drained, she was kept nil by mouth and underwent esophageal stenting. So now the question is when we should remove the stent in these patients. The literature says mostly after couple of months, 2 months, because it's a benign condition, the fully covered stent was put. What are the chances of recurrence? Whatever fully covered stent in benign strictures, they have a short success rate of 1 in 3 would get better. So they always, we tell the patient that 30 to 40% success rate. Should we be trying other drugs like biologics, IL-13 blockers to manage her esophagitis? So just the eosinophilic esophagitis, imbibing fluids with medicines, modifying food, prolonged meal time, avoiding meat and bread, chewing excessively, turning away food. So these are all the medical conditions apart from eosinophilic esophagitis which are associated with eosinophilia. There are many of them. The management is 3D: diet, drug, and dilate. So the meta-analysis shows that PPI gives response in 2 out of 3 patients. Topical steroid is not superior to PPI. First line, if the esophagus is narrow and long symptoms. Dietary 6 food elimination and now 4 food, 2 food elimination diet have come with variable response. It's challenging. Adherence is a big problem. I think I'll end here. So if there are any questions, comments, most welcome. Thank you. Taken a little more time. I welcome Dr. Prashant. Yeah, Rajit, Mike.
So my question is in eosinophilic esophagitis. So in other patients, not in this specifically. So what is the duration of steroid therapy that would be usually prescribed?
I think the treatment is quite long because we sometimes able to find the allergen, then it is okay. But if you're not able to find the allergen, and there are probably possibly some genetic factors also involved in it. So the treatment has to be for quite long time. Now, this patient has been suffering for last 6 years. So, I mean, unless until you find the allergen and you are able to avoid it, things doesn't happen. And majority of the times it's a food allergen.
if I can comment.
Yeah, actually, Saurabh has delivered a lecture recently. So.
Yeah, so eosinophilic esophagitis is starts earlier, but it's picked up sometimes late. And the issue is the natural history of disease progresses from inflammation to eventually fibrosis. So if this is a patient who is in her, I think 40s, 50s, at least 50s or not younger. So this is a predominantly fibrotic stage right now. So all our efforts with medicines are not going to work because it's a mechanical problem with a fibrotic stricture. So we can add steroids. We don't know how much it will work. We've been doing, and you have to basically give it permanently because there's really no stopping steroids. Ideally, you would want to do a 6-food elimination diet and identify the triggers. But she's been someone I'd been following for a while. So in fact, something that I've learned also recently is that 6-food elimination diet, which I used to think was 3 months to figure out, try 10 endoscopies, which is your allergen. In fact, now you can just go to 2-food elimination diet, milk and wheat, stop it and see, because that will care for 50% of the patients. But this is patient who's like, further out in the natural history, but earlier on, you can just do milk and wheat. You're otherwise eliminating all 6 foods, doing them 10 endoscopies is not practically possible. So that's something that can be done now. And then I guess, as Sir explained, I mean, I think long-term steroids is what you would have to do. But ultimately, these are very tough patients to manage. They have long-term symptoms, constant dilation, a lot of reassurance required. So I guess, Shrisha, do you see patients like that? I think it's more a Western disease because in the US, you'd see one every week. So is that the same thing in UK, Shrisha? If you can unmute yourself, and also Salvatore, I guess you must be seeing some of these.
Yes, a great presentation, Dr. Mukevar, some interesting cases. And regarding the eosinophilic esophagitis, again, as Saurabh said, we see quite a few cases. And again, as I mentioned, they're put on long-term treatment. Just to say a couple of points about the endoscopy in these patients is also that when you're taking the biopsies, when you're not very sure, Dr. Mukevar mentioned about the perforations, but also sometimes when you take a bite, sometimes it scares you. If you've never seen this, you get kind of a pseudo perforation. It is not a perforation, but because it forms like a web on the mucosa, when you take a biopsy, if there's any training around, if you've never seen this, it might scare you. But most of the time, it's not a perforation. The other thing which we also see in the Western world is that we endoscope lots of elderly patients for an ERCP, endoscopic ultrasound, and we have diagnosed 80-year-old, 90-year-old while doing an ERCP because they do not mention their symptoms of dysphagia, but when you're putting the scope down, and then you find that there might be some difficulty in passing the scope down, and then when you change over to a gastroscope and we have taken the biopsies, that's confirmed eosinophilic esophagitis. So this is quite common here.
Sample है उसके बजाय
Yeah. Any other questions? Ashwini, do you find HSV?
Sorry,
Yeah, please go ahead.
Yeah, that's I wanna. So thank you very much for your invitation, and also in Europe here is esophagitis, eosinophilic esophagitis is very common, and it's fascinating nowadays also for the new treatments and also for the assessment to the response of treatment. And so I got some points that I kept from also the last DDW in Washington, D.C. About the assessment of the response of treatment for the esophagitis. And mainly they said the endoscopy and biopsy sampling, and not only symptoms alone are needed to assess the activity of this disease before and after any changes in dietary elimination therapy or pharmacologic treatment. Okay, that's important because sometimes this disease doesn't follow only the symptoms, and so we need to recheck with the endoscopy and with the biopsy again to see if if the activity is down of this disease. Thank you.
Do you have experience of these IL blockers in other than dietary and steroids? Any experience about the new drugs?
No, at the moment
Filimab?
we don't have here. We are here in Italy. We don't have them, but we are just going on with PPIs and steroids.
Same here as well. Yeah.
Yeah, the HIV patient, I just want to ask whether she was on treatment for a long time or it was recently started, because at CD4 of 200, CMV is a disease which is commonly seen at low CD4.
Okay.
So if it is at 200 CD4, probably
I
it can
think
be
both the parents had HIV. She was diagnosed as HIV for birth. She presented to us on 14 years of age. She was diagnosed as HIV on treatment for a long time. And in fact, she had so much dysphagia that she had a pinpoint lumen of the esophagus. We dilated, taken a biopsies, which has shown both positive.
then more likely she is not on regular treatment, because someone who is
Maybe, yeah,
virologically
she is a
controlled,
pediatric patient,
it's
so
a bit unlikely to have
yeah,
CMV at
likely possibility.
Sir, one more question. The question is regarding ulcers, like we see a lot of esophageal candidiasis, but recently I've seen that patients not having comorbidity, non-diabetic, non-elderly, non-immunocompromised, also have candidiasis. Have you also come across, because a lot of times the physicians call
I think it's very common because patients go on taking anti-acid medicines, PPIs. That also is one of the precipitating factors for all these medicines, I feel. And it's described in the literature that the patient should not be immunocompromised. In the elderly people without diabetes and things like that. Even young patients we have seen, there may not be any factors, but that's very common.
For an ulcer which we suspect for HSV or CMV, what is better, to take a biopsy and send it for HSV CMV PCR, or is it better to send it for IHC for HCMV?
See, basically the PCR positivity rate is around 90%. So if you combine histopathology together with PCR, you tend to get a diagnosis. IHC, I don't know.
IHC for CMV.
Test
Yeah.
with IHC, with histopathology, IHC as well as the PCR.
Because PCR positivity can be there, as Madam said, as a commensal also. Because you see a lot of
Yes,
IVD
yes.
patients who have CMV, but unless you see the cytopathic effect and IHC showing.
Exactly. So both the tests, they are complementary to one another and they should be done hand in hand. Whenever there is equivocal or uncertainty on the histopathology, then only we go ahead with the PCR techniques. Otherwise, if we see cytopathic effects on the histopathology, to confirm the diagnosis, PCR can be done. Again, if there are typical ulcers on endoscopy with a presumptive diagnosis on endoscopy, the diagnosis can be confirmed by both the techniques.
Yeah, in fact, if you want, it should be everything. Endoscopic appearance, histology, PCR, and ISA.
Yeah,
Everything together probably would be around more than 95%.
Yes, yes. It should be a triangular approach. All the techniques should be.
First of all, sorry for joining late. The last case, the esophageal eosinophilic esophageal. I remember of the terminology called as scabbard trachea in thyroid. So it was almost looking like the esophagus was looking like scabbard. It's where you put the sword.
Yeah,
It was looking like that. One thing, sir, you said that she had undergone dilatation 4 times in 4 years. So it was ignorance of the patient, or she was not counseled well?
No,
because
that
I feel
was, I think that
the slide mentioned 4 times.
No, it was not ignorant. Basically, it was symptom based. I think Saurabh is following, so he can.
Yeah, no. Yeah, no, actually, she did undergo, I think they may have mentioned 4 years in 1 year before. She probably had more dilations before that. It was basically give steroids whenever she would have symptoms and she comes back for dilation. So such is the case for most of our patients. I may want to bring them back in 10 days for like 6 sessions, but they will not.
So what's
They-
the ideally?
So ideally for any strictures, by and large, for any standard strictures, ideally 7 to 10 days. Most people do 2 weeks, which in my opinion is long. If you want to do a successful dilation, you want to do 7, max 10 days, bring the patient back, forget the symptoms. You want to do keep serial dilations in 7 to 10 days until you reach a good diameter.
Yeah.
Strictures, what happens is you take 2, 3 weeks later, the guy comes in, oh yeah, now you have symptoms. Obviously, because what I did for you has now become very narrow. So now from 7, I started, it took you to 12. You took 3 weeks. Now I'm back to 7. So if
See,
you
the end of
Yeah.
dilatation is either you attain a diameter of 15 mm, then stop. And then depending upon symptoms, you do it. So as you rightly said, 15 mm is the maximum.
Because that
Dr.
is
Mukherjee, do you have any of your patients are on self-dilatation? So some
Yeah,
of very,
no,
very-
not very popular with in India. Not very popular in India. Self-dilatation.
No,
I mean,
not really.
it's in North. We have seen some patients in US also. There are patients on self-dilatation. In fact, I was discussing with Dr. Kulvinder Dua, who is from Milwaukee. He is advocating weekly dilatation, and they have probably published a paper also on that, that weekly dilatation is better. But for our patient to come weekly for dilatation is a problem. So we probably ask them to come once in 2 weeks. But difficult patient, resistant patient should be offered a weekly dilatation and maybe triamcinolone injection also.
Yeah, good evening, sir. Sir,
Yeah.
Yeah, please go ahead. Yeah.
sir, I would like to have one question regarding the refractory stricture of dilatation. If the patient have a refractory stricture, what are the effect of triamcinolone, that is Kinacod or mitomycin C? Any idea about that?
See, triamcinolone, the PGI people, especially Dr. Rakesh Kochar, has used it very extensively and has shown that injecting triamcinolone is associated with reduced dilatation frequency. So we normally use triamcinolone for corrosive strictures routinely, but difficult to treat patients also are being treated with triamcinolone. As far as mitomycin C is concerned, there are reports that mitomycin C works as an anti-neoplastic agent, thereby because you damage the cells and the new cells, they regenerate and they cause fibrosis. So this works as a topical anti-proliferative agent leading to, but there are not much reports of mitomycin C helping the patients. So basically, there are few case reports only.
Yeah, I think mitomycin C is a very, it's also something you have to be very careful of. So it cannot be just applied easily. I mean, you have to have an overtube only locally applied to the esophagus. And if it gets exposed to other parts of the body, it can cause problems. But yes, as Sir said, very few reports. There's only one nice series where they've used it with some success, but it's not, I mean, it's only for refractory cases can try. We don't have much of an experience. I don't know if anybody else here has an experience.
We do use mitomycin C injectable at the local site, but I think we'll discuss that later. We'll move on to the next case. The next case is a case of cirrhosis and achalasia and poem. And
Thank you,
Dr. Bhushan will be presenting the case.
एक मिनट cirrhosis, yeah. Yeah, good evening, all chairperson. So my case is a 58-year-old male who was diagnosed to have a chronic liver disease, which was caused because of ethanol, but now in complete abstinence. And he was having a CTB staging B and having a MELD more than 15. This guy presented with an history of an more about dysphagia since 3 months, occasional chest pain, regurgitation for last 4 to 5 years, which has aggravated since last 3 years, last 3 months. And the patient complains of had a weight loss around 4 to 5 kg in the last 2 months. On examination, the patient was not having any signs of any chronic liver disease except mild pediledema. And this in endoscopy, which was done outside in the month of January, suggests that patient having a grade 1 esophageal varices with dilatation of the esophagus with mild resistance felt at lower esophageal junction, and it may be a case of an achalasia cardia. So with that report, the patient landed up in MIDAS. We did a basic investigation, which was showed that a patient having a low platelets. The bilirubin is ranging around the range of around 1.5 to 2.5 in entire last 3 months. Enzymes was mildly elevated. Albumin was slightly low. INR was slightly elevated, and the XHS and 2D echo was within normal limit. So with that background idea of dysphagia, we did endoscopy. And endoscopy, as you can see, is a very dilated and tortuous esophagus. And there are significant liquid residue. And varices was nearly of grade 1 rare. And there are significant resistance. Yes. I can able to see, I can feeling a very pop out like a feeling when I went inside into the stomach, as you can see. So therefore, I can definitely say there was a resistance felt at G junction. The esophagus was dilated, tortuous, more like a sigmoid esophagus. And then we did an endoscopy, esophageal manometry, and the esophageal manometry suggests that it's more like an classical type 2 achalasia with elevated IRP level and absence and pan-esophageal pressurization was also seen, and absence peristalsis was also noted. So it was basically more than a tortuous esophagus. It was a more a classical of type 2 achalasia cardia, which was reported on high resolution manometry. So we made a diagnosis. He's having a compensated chronic liver disease with a CTP child B and achalasia cardia type 2 with the CART score of more 6. And with a discussion with the family and various options were discussed, we preferred that patient may go, we may offer him an per oral endoscopic myotomy as a treatment for his symptom relievation of dysphagia. So at the end of the day, when we take a decision of any intervention procedure in cirrhotic patient, assessing the hemostasis test is very important. As we all know, the conventional coagulation tests like prothrombin time, APDT, INR, and platelets has various drawbacks as it measures only the procoagulant activity but not the anticoagulant activity. Since this sample is centrifuge, there is a lack of representation of the cellular parts of the coagulation in this assay, and the interaction, as you also know, that interaction between the procoagulant factors and the anticoagulant factors and platelets are not correctly assessed by this conventional coagulation profile. So now in our MIDAS hospital, we have done a very nice, we are doing a global visoelastic test, mostly a ROTEM, but also TEG also have been done. And basically it is a very point of care testing, is a rapid diagnostic bedside test to aid a clinician in directing the therapeutic intervention. It utilizes the whole blood and provide insight to both cellular as well as plasma-based components of coagulation pathway. And it provides a very dynamic information about the very global hemostatic function, about beginning from a clot formation, clot retraction, and fibrinolysis. So basically, not only giving an idea basic of about intrinsic, extrinsic pathway, but also it gives a very nice idea about clot formation time, clot breakage time, and it definitely giving in studies, it definitely in cirrhotic and transplant patient, ROTEM and TEG are doing a very good results. And accordingly, depending upon the coagulation, whether the patient is having a coagulation more or hypercoagulation, we can transfuse FFP, heparin as per the report of ROTEM and TEG. So we did a ROTEM, and ROTEM said just a mildly elevated clotting time, though patient having a raised prothrombin time and raised INR. And we preferred that, okay, we may require an FFP during for elevated mild clotting time. So with the due risks of an F1, just a child B patient with an grade 1 esophageal varices, we prefer that we can go with a POEM. So as we can see, we can enter into esophagus. We just elevated by using a needle. a very nice bleb was achieved. And then we do an submucosal incision to enter into the tunnel. There was hardly any, we can see a mild bleeding around there, but it was very controlled. And we can easily lift it, and then we can enter into tunnel and do a submucosal incision. And it was, I think, some middle during incision we found a slight bleeding vessels, but it was really manageable with our instruments what we have. No active torrential bleeding was noticed. Around we preferred on 8 centimeter tunnel, more on 6 centimeter on the esophageal side and 2 centimeter on the stomach side. We can see a palisade vessel here on the when we reach into the stomach side, we do a proper incision of dissection of this of the fibers. Yes, you can see a very nice long tunnel made into esophagus and more in 2 centimeter more into a gastric side. Yeah, and we start doing we use mostly a triangular knife for initial myotomy. Yeah, and thereafter the myotomy was also proceeded. And we hardly noticed during the procedure there was any torrential bleeding that required any form of intervention. Yeah, as you can see, a nice myotomy was performed. And then we can see now the scope was very nicely entering into the esophagus, and the tunnel was closed using our clips. So it was a very standard poem what we perform in this patient of a type 2 achalasia. Sorry. So post-procedure barium milk flow, there is no extraction of contrast, started orally with liquids, patient tolerated well, and patient was stable hence, and were discharged on almost day 3, day 4 as a natural patient of any non-cirrhotic patient. And follow-up endoscopy was done at around a month or so, with there is no resistance at G junction. There is a post-poem barium. We can see easily the barium can flow into the stomach without any retention of contrast into the esophagus. So as you all know that poem has become very widely accepted therapy for a management of an advanced achalasia. Compensated cirrhosis, portal hypertension was traditionally considered as a contraindication to the poem. But now there are various case reports and case series which has reported that we can really perform very safely and effectively a poem in a very cirrhotic patient. This is one of the very novel case which was published in UEG, which they had done also a decompensated patient with a significant cirrhosis, where they done initially a tips for complete eradication of varicose, and thereafter they had done a poem. Up till now, this is the largest case series of a multicentric case studies which was done in Europe, where they have seen that around 14 patients was achalasia cardia, around cirrhosis was seen, and all the modalities including dilatation, endoscopic dilatation, botulinum, and the poem. Among all the 14 patients, 5 patients, around 3 to 4 patients having a poem has successfully underwent a poem procedure, and this concluded that all the conventional achalasia treatments are safe and effective, and provided that the interventions are performed with a specialized setting. So basically, we can really perform poem if the patient has really a class 1 compensated compensated cirrhosis, along with having either a no esophageal varices or grade 1 esophageal varices. So in take-home message of this case, like liver cirrhosis typically exhibit abnormal coagulation parameters in conventional coagulation test. ROTEM is a very holistic blood coagulation assay that must be performed in the patient of doing any intervention procedure. And the take-home is that poem in cirrhotic patient in a mostly incompensated is very safe and effective. Thank you. Yes. Shall I proceed with second case, or I can you can take a questions from first case, sir? Yes.
I think we can finish the second case.
Second case?
Then
Sir.
take questions.
Why second case? Sir? Yeah, this is another patient of achalasia cardia for which we underwent POEM, and let's see, a very interesting story is lining up this patient. Yeah. This is a 53-year-old male who's having a significant, with having a multiple comorbidities in the form of diabetes mellitus, which was controlled, hypothyroidism, and bronchial asthma on inhalational therapy. She was also had a history of supraventricular tachycardia, for which she was put on beta blocker for a year or so. So this patient, this lady, presented with a history of a dysphagia with occasional regurgitations from last 6 years of duration. She gives that she has some history of endoscopic dilatation done quite a couple of years back. Quite 4-5 years back, for which no details was provided with us. So this patient has had a recurrence of symptoms since the last since more about last 5 to 6 years, which aggravated in last 6 months. So for this patient, we did an endoscopy, and endoscopy showed there is a definitely a myself I did an endoscopy. There is a resistance felt at quite G junction, as you can see. This time esophagus is having quite significant resistance. I was finding quite difficulty to enter into esophagus. This time also the esophagus was quite dilated and tortuous. And I can see, I went into stomach with similarly a pop-up feeling, which is very classical of any achalasia patient. For the similar patient, we approached and we did an in manometry. We show an elevated IRP with DCI more than 8,000. So it was like it may be a type 3 achalasia versus hypercontractile esophagus. Yeah. So for this patient, as more about type 3 achalasia, we planned a tailored POEM based on the manometry result, with myotomy extending nearly 1 centimeter above the contraction segment in esophagus and 1 centimeter below the contraction segment in stomach. And this time, since the patient having a type 3 achalasia preferred a very long length myotomy, which planned near over 22 centimeter. And pre-POEM ECOG score was definitely elevated to more than 3. So pre-POEM workup, as we do, was really within normal limits. Since the patient was having a significant comorbidities, we really involved in pulmonologist and cardiologist to be taken care of 2D echo and PFT, and rest of was really manageable. And the patient was given a mild to moderate risk for his POEM procedure. So yes, as usual, we did a submucosal incision. A nice bleb was obtained, and incision was made, just like a previous case. And we didn't hardly found any problem in entering into the tunnel. With a little bit of lateral incision for lateral dissection, we prefer to enter into the tunnel. Yeah. So yes, so we can enter into tunnel. After entering into tunnel, standard dissection was done. And yes, I can see after dissection, a long, nice myotomy can be, submucosal tunnel can be seen. Yes, long, almost 22 centimeter myotomy was as we planned. And thereafter, we planned to do, we proceeded with the myotomy. Yeah. So it was really a bloodless, free, standard myotomy. Yeah. A nice muscle was cut. Yeah. Yeah. So as you can see, a very nice myotomy. The muscle is very nicely cut. Entire almost full length myotomy was performed, and thereafter, as seen previously, we closed the tunnel using clip. Sorry. So a post-POEM course, the most important point in this case was that during POEM procedure, this patient really had a hypercapnia with elevated EtCO2, and also had a capnoperitoneum and subcutaneous emphysema that required a 3-time intervention during the POEM. So it was not a little bit challenging during the procedure. That patient, we had to interrupt the procedure for around 3 times because of elevated, but everything was managed by using mostly for capnoperitoneum, we insert a small needle into the peritoneum and entire CO2 was washed out. And thereafter, post-poem, the patient was required to required a very high ventilation. X-ray suggestive of capnothorax. Needle decompression was performed successfully. Ventilator requirements was reduced in less 24 hours, and the patient was extubated next day and put on NIV. And the patient was having treated with an antibiotics and eventually shifted to ward almost day 3 on ICU. So this patient, because of significant comorbidities and the patient has developed some gas-related adverse events, we managed it with conservative management with little intervention during the procedure, but eventually the patient did well and was shifted to ward after day 3. So barium study showed no leak and was started orally. It improved gradually and was discharged in stable condition. So now the case starts from here. So after post-poem, the first challenge that patient came to us, that patient started to having some another like a somatic symptom, that patient having some nausea, headache, occasional dyspepsia, insomnia, anxiety. So very frustrating when a patient, most of our poem patient comes very happily after for our follow-up. And this time we proffered, okay, the patient having just a mild dysphagia, occasional dysphagia, we treated with a PP as an anxiolytics. So patient symptomatically remains really better, but again started to have some occasional dysphagia. So this time we did, so we can see a nice myotomy scar along with the clips was there. And this time this patient was having more about an esophageal candidiasis. As we recollect the history, the patient was taking inhalational steroid for his asthma treatment. So this was also having some predisposing factor. The patient has developed some sort of candidiasis. We taken a brush and sent, and we also treated perorally with fluconazole for around 2 weeks. So another challenge came that patient went very nicely with fluconazole for another 2 months, but patient continued to then have a recurrence of dysphagia, and this time another complaint erupted, this patient having to develop a odynophagia. So we again did an endoscopy, and this time we can see there is a ulcers, and there is something like a green sticky material which is seen also along the ulcers. The G junction was very nicely opened. The scope was going very nicely. There hardly was any changes of any significant esophagitis was noted. And this time we take a biopsy from that ulcers, and the biopsies was more about a regenerative, like just a very non-specific inflammation was really noted. Does not give any particular idea about what's going with why the patient is having an ulceration. So now with the further discussion of patient, even Dr. Saurabh sir only pick up this case, that she was really, she was consuming, she has a very habit of eating a pan with chilies at night before giving to bed. And that was a really concerning problem, that our patient, we had done such a nice procedure, and she continued to consume such a pan and chilies, very awkward to hear. And that we thought, okay, that can be one of the cause, that we can see some pan and some chilies, that may be the reason that she is consuming. So finally, with all this proper counseling of anxiolytic, managing his multiple comorbidities, managing his the ulcers, symptoms improve after stopping pan and chilies. Patient follow up on 8 months symptomatically. Just we called yesterday. She was fantastically doing well. She complained on phone that she having some problem with rice, but she's will just do an manometry once she comes with us in couple of days, and she is doing very well. So really, thank you. So at the end of it, the bottom line of this case is not all dysphagia after poem is a failure of a poem. We had to really look out for some other indications, such as as such patient having dysphagia because of ulcerations, this patient having some issues of this pan and everything. So that was a agenda of presenting this case, that okay, not all dysphagia after poem is a failure of poem, or some reflex esophagitis is also counted. Thank you. Yes, sir.
Excellent presentation. I never heard of chili pans.
Never, sir. Me, sir. Sir only pick up that. Never, sir. How come? We test other things, not pan.
No,
Chilies.
I think this lady was, I think as Bhushan pointed out, so most patients after poem do fine. Like the next day, they're like, I'm the happiest person in the world, 10 years of symptoms, one day it's gone, so they are so happy. So this patient happened to be related to a doctor and a family friend. So I think the expectations were high. And then this lady, we had a challenging course, CO2, ICU, this, that, got better, still had a lot of psychosomatic component, anxiety, dysphagia, treated, not better. comes back, fungal esophagitis, treated, better, again has problems. And I see these weird ulcers, and I said, now what is going on with her? 4 months, we are just trying to battle and get her fine. And then towards the end after that, I called her back, and then she said that she was eating the pan with chilies for digestion purposes. And what happened, I think, is that also that this patient has a poem, which is a long poem.
Yeah.
So 22 centimeters of myotomy. And now there's not much motility left in the esophagus. And she wants to eat it at night before going to bed.
Yeah.
So that all pan and chilies are lying down in her esophagus all night. And that's what's causing multiple ulcers. And I think, again, counseling, I suppose, for the patients to recognize that your muscles are not working anymore. So you have to use gravity, liquids to make sure everything goes down and not just eat anything before sleeping, I think. Yeah.
Yeah.
Have you had any experience to like see challenge in dissection in post-tibial scars? Those have already undergone multiple banding sessions.
Absolutely.
In that, do you find any challenge?
Yeah, Gaurav, definitely. This was patient having a no history of banding for our patient. That's why the patient was having a very nice elevation of this thing. But definitely the patient who's having a repeated history, even the literature I went into these 14 cases, none of the patient has a history of banding. None of the patient. One patient, what I said, only EVG that they had decompensation. The patient has a history of some one-time banding done some quite years back. They've done the portal hypertension reduced not by banding, but by doing tips or something, a procedure. So definitely by doing banding, we get a significant scarring, and we may encounter, theoretically, definitely we can encounter the difficulty in dissecting from a muscle, and we can encounter some problems. Theoretically, yes, no doubt. There is no issue in that. If the patient has significant scarring, it definitely get problematic of dissecting from a muscle and causing mucosal injuries.
Going across the junction.
Actually, not in case that definitely one problem is we are away from the mucosa, sir. At the end of a day, yeah, we are away from the mucosa. You are very correct. It may comes on a way and cause a significant bleeding. It's no doubt in it. Personally, I don't have any experience. Maybe Saurabh sir would have a good experience in poem. He had done some really high esophageal varices case.
Varices are not going. Yeah, the varices are not going to be 360-degree, right? So you have to identify the areas without the varices to tunnel into. Because your tunnel anyways is going to be 1 centimeter wide. So you will certainly encounter dilated vessels.
If it bleeds, you will still band it, or?
No. You can then use our methods. We have our coagulation
graspers and everything.
So recently we did a ESD in a patient with hemorrhoids at anorectal junction. So I encountered that and tackled them.
That works.
Yeah.
Okay.
But obviously not large varices. I don't know. I've not done in large varices yet, so I wouldn't be the right person. I guess anybody online, Srisha or Salvatore, any of you have done cirrhosis and achalasia patients?
Yeah,
and poem, I mean.
I wanna point out some key points about the cirrhosis and achalasia treatment. So, according to our experience, managing portal hypertension is a key point, together with performing the procedure that you are more confident with. Okay, because if you are confident with poem, you can go on with poem. If you are confident with dilation, go on with dilation, because they have similar results. Also according to the literature. But so for example, we are confident with both procedures. So we decide patient by patient which is the best option for him, and we decide also mainly on the features of the patient. That means that patients that have high risk, for example, high anesthesiological risk, they can perform, for example, dilation more than poem. So the multidisciplinary team is important to manage this type of patients, I think. Okay.
Yes, Saurabh, if I can make a comment as well. So I don't know whether I'm right, but do you agree that patients with cirrhosis has more symptoms with achalasia, mainly because of autonomic dysregulations? They have sarcopenia, they're more frail. That's my first thought. And also your team in general and moreover, India in general has got now significant experience in POEM compared to anywhere in the world. And what's your failure rate, or what is the percentage of patients who require repeat myotomy in following the POEM?
Yeah, thank you. Actually, failure rate once we have done a poem successfully, I'm trying to remember, maybe 1 out of 1 or 2%. That's what we are looking at. But again, our follow-ups are only in the last 3 years and 4 years. So I would imagine maybe 5 years from now, my numbers may be higher. As we see all those Hello's myotomy 20 years back now coming with recurrence of symptoms. So I think over time, any myotomy, doesn't matter which way, patients will have recurrence. But I do feel that compared to a surgical myotomy, a POEM myotomy should not be any different in terms of the success rate if it's done properly. Cases in which you cannot do it, you have challenges, you didn't reach, you had problems and you don't think you did correctly. Yes, I mean, that's a different ball game altogether. So I wouldn't say that is a technical success. But once you have achieved technical success, you've achieved the right myotomy length, I don't think the recurrence rate is exceedingly high in the first 2 years. We are looking not more than 1 or 2% in our experience. And as I said, over time that will increase, but in the first 3 years, it's hardly any.
Thank you.
Preferred mostly for posterior. This was posterior. This patient capnoperitoneum. Yeah. Gas related. Yeah. That can happen. I mean, no, sir, it is mostly a gas-related complications, which profold CO2 get absorbed through muscles and enter into the some sort of peritoneum, which is really a very common side effect. It is hardly anything which was reported in any standard POEM. 7 to 10% of patient has got gas-related portion, which is very adequately managed during our procedure. Okay. Yeah. Okay.
Yeah. So gas and capnoperitoneum. So remember, we only use carbon dioxide because it can get absorbed. And right, exactly, right. So having a capnoperitoneum laparoscopy is a part of the procedure. So same thing in POEM, CO2 is there. It trickles down. Sometimes they have subcutaneous emphysema, which goes on in 24 hours. We don't bother with that. The challenge really lies when the PCO2 levels go above 60. The main problem is cardiorespiratory. Abdomen is okay because we can just decompress it. Cardiorespiratory means one is respiratory, which can lead to higher ventilation settings, and then most of our anesthesia colleagues don't like that, so we have to wait. So we have to stop 2 times, 3 times, but then it settles and then we do it. And second is a very dreaded complication, which we had in one patient, which is capnopericardium. And I think it was in earlier cases where we did not take into heed the PCO2 levels of 70 and 80, which we just wanted to keep going. And that happened because the patient was of a small body habitus, 35 kilogram old lady, and she had more CO2 than she could handle. And then it made its way into the heart. And when she got out of the POEM, then she coded. And then we realized it was a capnopericardium, which led to, and she revived. Next day, she's walking, talking fine. So that was one dreaded complication. This is the other one, where long recurrence, and we could not predict it. Low flow CO2, everything is standard, same case, nothing different. Just some tissues, sometimes CO2 goes up. Here we stopped it. Then she developed this trickling of CO2 in her lungs, and then eventually capnothorax. So you don't need a chest tube. You put needle, air comes out, done. Chest tube is when you have liquid and contents. So without chest tube, needle decompression out, CO2, lungs expanded, PCO2 fine, everything fine. So yeah, I don't know about that actually. It should not be, but I think data says similar. Posterior is just because we are used to it. We can do anterior also. I mean, that's not a problem.
Same, sir. Very, very standard. We use all the measures of low CO2. Anesthetic is using all tidal pressures. What is a mean to happen? Some patient become symptomatic. For that, we need to do some needle inside. Some patient doesn't become symptomatic. We proceed with that POEM and can successfully conclude it. Thank you, sir. Introduction. Yeah.
I have some questions.
Yeah.
From online questions. There's one question. Is there any specific histopathological feature for drug-induced esophageal ulcers? By S.K. Sharma.
So there are no like specific features for drug induced. The features they really they like overlap. So just based on histopathology, we cannot tell whether it is drug induced or whether it is infectious or whether, unless we have a clinical scenario in the context of the clinical scenario, in context of clinical suspicion, we give a diagnosis on the clinical history, based on clinical history. So there are no specific findings as such.
There's one more question by some anonymous attendee. He's asking, any experience of MMF in eosinophilic esophagitis?
See, as such, the condition is so uncommon with us. So we'll not be able to justify. Probably, I think the people or the international panel may be able to answer this question. MMF, mycophenolate in eosinophilic esophagitis. What is your experience is the question.
No, we have never used it. And again, the majority of the patients, as Dr. Francesco mentioned, they manage with PPI and oral budesonide. So standard treatment, majority of them.
So let me take this opportunity to welcome Dr. Shubhankar Godbole. He has joined as a consultant gastroenterologist. Come, Shubhankar. Come. Yeah. He has joined as a consultant gastroenterologist and ibidologist in our MIDAS hospital. Dr. Shubhankar Godbole has done his gastroenterology from AIG, prestigious institute of AIG Hyderabad. And his areas of interest are IBD and related endoscopic and intestinal ultrasound related procedures. He's trained very nicely in endoscopic ultrasound, which is a very emerging modalities and serve as a point of care investigation for managing of an IBD patients. He has a very keen interest in academic teaching and medical research and has published his research work in reputed national and international journal as an author and co-author. We really welcome Shubhankar and joined our MIDAS team. Very nice. Thanks. Now I really want to welcome another doctor. Come, Dr. Prajakta Sathone. She is joined as a pathologist and oncocytopathologist at our MIDAS hospital. She is basically a very gold medalist in MD pathologist. She has done his MD pathology from GMC Nagpur, and she has done his fellowship in oncopathology from NCA and Nagpur. And she has also done MBBS from this or Nagpur, Lata Mangeshkar. She is definitely has a clinical, she has having a very nice experience at Tata Hospital. She has been a consultant pathologist also at Arianth Hospital. I really welcome Dr. Prajakta as joined as a consultant oncopathologist with us. Yeah, Dr. Lanjava sir, please come and really welcome Dr. Prajakta ma'am. We can proceed with the further case.
I'd like to call upon Dr. Saurabh. So obviously, every time something's interesting, so let's find the needle in the haystack.
Okay. So good evening, everyone. Which one are we speaking? Okay. So, so let me start off with the first of my two cases, and Let me see this one, right? So it's titled Finding Needle in a Haystack, Managing a Very Challenging Upper GI Bleeding Case. So this is a 21-year-old male with no comorbidities, non-smoker, non-alcoholic. So he presented initially at an outside hospital in November 2023. Presented with hematemesis and had a significant quantity of GI bleed. And her normal hemoglobin in the range of 14 is down to 8. And then he was admitted, received 3 units PRBCs, and an endoscopy was performed. And this is in Riva and MP, where they found a protuberance in the fundus. They thought it was a cyst. They took biopsy. They did some sclerotherapy at the protuberance and basically tried to control the bleeding. So then a CT scan was done as well, which showed changes of chronic pancreatitis, chronic splenic vein thrombosis, and some thickening along the gastric wall. So in this case, patient went back in November. Again, after this endoscopy, had another episode of GI bleeding. Again, significant quantity. Again, hemoglobin dropped to 6.8. 3 more units of PRBCs given. Then he decided to come to Nagpur for second opinion. And here he was seen at another facility in Nagpur, where he was felt to have maybe an isolated gastric varix, and a glue was injected in it. December, uneventful in that sense, no hematemesis. An endoscopic ultrasound was done as well outside, where they felt that it was a mucosal lesion, protuberance, there was no varix. Biopsy was taken, showed some gastritis. January for him was uneventful. February, another episode of hematemesis. Again, significant quantity. Hemoglobin down to 7.5. 2 units of PRBCs transfused. An endoscopy in February, again by the same clinician, felt that there was infiltrated gastric mucosa, gastritis, query neoplasia. And then he ended up coming to us basically for further management. So if you think of his scores before presentation in the last 5 months, he at least had 3 or actually probably another 4 episodes of hematemesis, required more than 10 units of PRBCs, 3 EGDs, 1 EUS, and still no answer, and also a CT scan. So in our center, we initially did a CT to assess if there's anything else that we can find. And there was evidence of splenic vein thrombosis. And there was dilated and tortuous vascular channels with some splenomegaly. So that's all was found. So we proceeded with an upper GI endoscopy. And on endoscopy, you see there's this protuberance that is visualized. And this is on narrowband imaging. And I was almost tempted to snare it out. Maybe a polyp, we didn't know. We were not sure what is going on. So this is what was seen on retroflexion. It's just below the G junction, about on the lesser curve. Okay. So yeah, and then initially we start with a linear echo endoscope, which is used mainly for biopsies and therapeutic purposes. So initially I could see, there were changes suggestive of chronic pancreatitis, small pseudocyst, really nothing particularly impressive. But nothing else that could add to my knowledge in terms of management of this patient. So I said, well, clearly the guy is obviously bleeding a lot, and you can see these large collaterals outside the stomach over there. Right. So obviously now we have an EUS, and I'm not sure what's going on because I see large collaterals, splenic vein thrombosis, something on the mucosa. I was not sure what's going on. So I decided to put a radial endoscope, and this is an echo endoscope, which is for those who understand EUS. We give 360-degree views. So sometimes it gives enhances our ability to see things. So here we are doing a radial echo endoscope. Is advanced. You get nice some different sort of views here, and this is the protuberance, which is about 1.5 centimeters in size, and you can see this is basically Is a pointer, please? Yeah. So this is involving the mucosa. And then I could very carefully see that there was this structure which is going towards this protuberance. And yeah, okay, I can show from here with this pointer. Right, so what we did was use a Doppler, and it was not picking up any Doppler signal. So initially it looked like a vessel, but then when I used the audio power Doppler, you could see there is a little bit of flow in that structure. So it turns out this was a vessel actually, which was now finding its way from the splenic vein thrombosis from the vessel, coursing along through the gastric wall, and it was going to the protuberance and opening there. So you can see the vessel now. Then I switched back to the linear endoscope and then again decided to look a little more carefully. And then I discovered that, yeah, it did exist, but was probably hard to pick up on linear. And now I could see and confirm that it was actually the same vessel. And we could measure it. It was quite tiny. It's about 1.3 millimeters. Yeah, and then I ended up, we use a 19 gauge needle, which we put across the stomach. And we could identify and get first time I put in, it was hard because to get the accurate location of the needle inside the very small vessel was a little challenging. So I pulled it back, reconfirmed, and then went back in. Now this time around, I could confirm that my needle tip is actually in the right location. And I decided to just basically inject glue that we use in patients with varices. And here we are injecting the glue successfully. It was injected, as you can see. Yeah. And this is the glue that forms a cast inside the vessel. And you can see the glue cast has trickled all the way down. And now here on the endoscopy view, you can see the glue cast in the stomach. So it had reached the right location. It came out from the stomach. In fact, I put more than I thought was required. But there you see. So that's the cast. And then we confirmed that based on Doppler that we're in the right location. Distal to it is that little bit of flow confirming that our glue was in the right location. And this is in April, and we are now in June. So 2 months out, this boy is doing fine. 3 days back, he had come and he has had no recurrent episodes of hematemesis now. So, yeah. So if you think about EOS Garrett vascular hemostatic interventions, really, we can maybe now doing this for cardiofundal varices, ectopic varices, a case of ectopic varices we presented, I think, in the last meeting, which was a small bowel varices, which we did across the rectum, and pseudoaneurysms is a new emerging treatment option to the US. So as you can imagine, this is such an unusual case that I could not really find any literature of people doing this. But at least this is a series from Michael Levy, who was who's someone I learned EOS from Mayo Clinic. And he had done this in a patient with Dieulafoy's lesion. But my case is not really Dieulafoy's lesion, this one here, which is a small lesion. And again, a patient with duodenal ulcer, they could find a vessel which is supplying. And fast forward, they did it in other 17 patients with non-pharyngeal GI bleeding with multiple failed standard attempts at hemostasis. For example, this is a patient with a rectal aberrant vessel, 1 EGD, 3 colon, CT entro, ligation, hemicolectomy as well was done. And then ultimately they could find this vessel and then take care of it with EOS. So I would say that EOS is an emerging modality for it's really added to our armamentarium here in managing this patient, because I don't think there would be any other way to figure out how this patient is bleeding from. And interventional radiology wouldn't probably be able to do much given the size and of the vessel and the location of it. So I'll end my talk on this presentation, this case here. We take any questions, or should I continue? Yeah.
Take questions at the end.
I see. Okay. All right. So I think we'll switch back to the slides, please. Thank you. Okay. So this is my last presentation. Yeah. So managing constant dysphagia and vomiting in a cancer patient. So this is our case, 66-year-old male with history of diabetes, hypertension, coronary artery disease, and history of CA at G junction, which is a poorly differentiated squamous cell cancer with liver mets. And this was diagnosed in July 2023. He was getting chemotherapy with Folfox trastuzumab and radiation. Initially developed dysphagia in November 2023, for which he underwent placement of a partially covered esophageal metal stent, following which his dysphagia resolved. In December 2023, turns out his disease was progressing, his chemotherapy was switched. And eventually in April 2024, he presented to us with blackish vomiting and dysphagia and regurgitation. So this is the endoscopy being performed, and the endoscope is advanced across into the mid-esophagus, and you can see there's a lot of esophagitis. And this is above the location of the stent, likely from the reflux of a lot of contents. So you can see the stent is full of food despite the patient being nil by mouth for a while. And this is the stent right here. And then we make our way into the distal esophagus. And you can see there's all this coffee ground color food, which is lying there. Okay. And what we realized is that the stent was actually impinging on the gastric wall. So we felt that this was the reason why he's not he's having trouble because of dysphagia, and everything is coming up because the stent was almost impinging on the wall as it had likely migrated down a little bit. So actually, I would like to ask audience or questions and gastroenterologists, what do you think you would do in this scenario? Just to have a bidirectional communication here. This patient has a partially covered stent. The stent cannot be removed. And this patient has all this food which is now there, and the stent is stuck against the wall. Any gastroenterologist want to comment on how we should treat this, maybe in your experience or so?
Maybe try to cut the stent.
Try to cut the stent, yeah. Probably, I think,
APC
would
can
be a
be used
little
to
aggressive, yeah. Okay.
cut the stent.
You can put in a Ray's tube, or you can put another stent which goes like across that stent, which
Yeah.
Forms a
Mega stent.
Yeah.
which does not impinge on the wall, but it goes like
Goes further down in the, yeah. Yeah, no, thank you. In fact, I mean, we were really not sure how to handle this situation now because the stent was not coming off. Putting a fully covered stent through it to have pressure necrosis and remove both the stents could be an option, which has been tried before for partially covered embedded stents, but not worked well in my experience. And I think we were really short of answers. So we said, okay, let's bring him back. So 8 days later, we bring him back for another endoscopy. This time we did put a nasogastric tube, nasoduodenal tube, and send him out until we is figuring out what we should really do with him. So this time around, what we decided to do here is, let's see. You know, let me switch this to duplicate slideshow 1 second. Excuse me, yeah, better. Yeah, so what we are doing, this is what was going on, right? So the stent is a little down and then it's impinging on the wall. So we decided to choose an Ovesco clip here. So we got an Ovesco clip and then we deployed it on one edge along the gastric body. You can see this clip being deployed. And somehow we could get the orientation fine, but then now it was on other side. So we said, okay, now what to do? We then got a standard clip because 2 Ovescos is very expensive. So we got a standard clip and then basically placed it on the opposite edge. And yeah, so following this now, I think it was better. So now we got a straight axis, 2 clips in place. Right, so this is what we did, and patient's fine. 2 weeks later, did well. Improvement in appetite, resolution of vomiting. Then he started chemotherapy and then developed recurrence of vomiting. So I said, okay, So again, having vomiting every morning after brushing, but no dysphagia or weight loss, but just not well. And now he has another problem. Okay, so we bring him back. Let me just, excuse me, increase this size a little bit. Yeah. So this one again now showed large amount of, one second, sorry. Yeah. So now we go in again. Now we managed to go inside the stomach. But now when you go in the stomach, despite 12 hours of fasting, this patient has a large amount of liquid and solid in the stomach. Right. So then we were not sure because it's poor patient, not well, dysphagia, vomiting, did one problem, fixed it, another problem, fixed it. Now again coming back to us with problems. So we said, okay, why not do a gastric emptying scan to see if he has motility disorder? And turns out that he had now delayed gastric emptying, suggestive of gastroparesis. It was confirmed on motility gastric emptying scan. So blood tests at this time showed anemia, severe hyponatremia, and low albumin levels. So we did his scoring, which we do for gastroparesis patients. So he was a score of 24 on 45, which is a standardized format to assess the severity of a patient with symptoms from gastroparesis. It's called gastroparesis cardinal symptom index score. So he was clearly quite symptomatic. So this case, now we decided to offer him a gastric poem. So here we are going now. This was a challenge because there was a stent in the esophagus, and through that, we managed to get our scope into the distal gastric body. And now you can see, as you can appreciate, as I'm trying to get the scope across the pylorus, there was a significant, almost significant resistance there. And this is what is a common finding in patients with gastroparesis, what we term as pylorospasm. So I think we've seen enough of poem videos today. I'll keep it brief. So this is a different poem. We are going here and doing a gastric poem. We go about 5 centimeters proximal to the pylorus. The entry, like Bhushan showed you in the earlier cases, is sort of standard, but just can be a little challenging in these patients as the scope is really looped inside. So here we go and find our way inside through the tunnel, do the submucosal dissection, and see. Right, and then in the gastric side, well, some things are a little different. Sometimes you find really large vessels. So this is an example of the large vessels that we sometimes encounter. And as we approach, now you can see here. So this is the pylorus. Now this ring here is this is how we identify. This is the duodenum. This is the pylorus. Very important to identify because if you start going deep in, then you may cause some serious problems because you don't want to go in the duodenum and tunnel there. It's a very thin structure. So if you go in, and you can cause problems. So here, what we are doing here is a pyloromyotomy. This is a different knife that I use here. It's called a insulated tip knife. The idea is that the distal edge of the knife should not hit any vascular structure so as to avoid bleeding. So this is a pyloromyotomy being performed. Now, this is different from esophageal poem, where we do cut longer segments of the muscle. But in gastric, we are very limited to 1 or 2 centimeters of the segment. We don't do more than that because I'll explain to you why we have a very focused and a limited 1 or 2 centimeter myotomy. But as soon as I'm doing this, the quote from my sort of professor who trained me, I remember, is the enemy of good is better. So at that point, I had done a very nice 1.5 centimeter myotomy, and everything was going very smoothly for this patient. You can imagine he's old, comorbidities, so many things going on. And oops, okay, great. So let me go back there. So we did this. And the reason I say that is because as soon as I hit the last part, which I had done quite well, actually, and then starts bleeding. So this is a very vascular area. And once it starts oozing and bleeding, it can be fairly challenging, because in compared to esophageal poem, the gastric side has many more vessels and larger vessels. So you can see here, now we start off with one bleeder, it's addressed, and then the blood keeps gushing. And what happens in these instances is there's sometimes so much blood that comes in, you really have to keep up with the views, and you have to be extremely patient, because when you cut the muscles in these areas, there are a lot of vessels in the intermuscular plane. And once post-cutting, they sometimes can start bleeding. So you can see here, again, we stop it, and then it keeps going on. So it came to a point where I did 1, 2, 3, 4 areas, which was stopped. And then finally, after 7 or 8 areas of coagulation, and you can see the peritoneal fat here, the background. Typically, this is not what we intend to do to cut the serosa. We managed to only cut the muscle fibers and come out. But in this instance, as it started bleeding, you put the scope, then the area stretches further, and that leads to this, but doesn't have a major consequence, because we are anyways closing the entry here. So that was the pyloromyotomy that was done. And here we have placed clips successfully at the entry site, and this is closed. So gastrograph and swallow showing a smooth passage of things from the esophageal stent into the small bowel. And post-procedure, the patient, after 4 weeks later, he came in this morning. So he had about 50 to 70% improvement. He had one episode of vomiting in between, but by and large had decent improvement in his symptoms. So just to recapitulate, normal gastric emptying and mixing is a very complex phenomena. It involves, to start with, fundic relaxation, and then fundic contraction, which leads to emptying into the gastric corpus, where there's filling and mixing of food. Now, antrum is the location which is responsible for churning the food into smaller pieces. And then the emptying happens with the contraction from the antrum, and the pylorus opens, and that allows the food to go in the small bowel. Now, what happens in patients with normal gastric emptying, when you have a high-fat meal, it basically slowly empties. So all patients who have fatty foods, it takes almost 4 hours, right, for most of it to go out. And liquids is much easier. So this is the curve for liquids. This is standard food. This is fatty food. The dotted lines are gastroparesis. So there's a much delay in gastric emptying. So gastroparesis is basically delayed gastric emptying, which results in slowing of the emptying of stomach into small bowel. Lots of etiologies. The most common we have been seeing is obviously diabetes, but can be post-surgical, post-vagotomy. And several things can lead to gastroparesis. Now, we could not identify the cause in this particular case. We looked for everything, and really nothing turned out. I don't know if it was chemotherapy related or in some way from the cancer impinging on the vagus nerve that had led to gastroparesis for this patient. So what happens in patients with gastroparesis are multiple issues. There's impaired accommodation, so they feel full really fast. There is antral hypomotility. So the antrum's role is to churn the food in small pieces, and that is hypomotile. So it's not contracting well. And third, there is pyloric dysfunction. So it's supposed to open and antrum to contract to let the food out. So here the antrum, the pylorus doesn't open. So the reason we do only limited myotomy is because we don't touch the antral muscles, because as it is, the muscles are not functioning well. Now, if we decide to cut it more, then we are causing more problems. So the focus is only mainly on the pyloric sphincter and the muscle. So we have learned that pyloric dysfunction is the pathophysiological problem based on this. And you can see this is based on EndoFlip, which is available in the West, will be soon available in India, which is evident in patients with gastroparesis and those with esophagectomy. You can see the pyloric compliance was much lower, suggesting that it doesn't open well. Symptoms include nausea, vomiting, fullness, bloating, early satiety. And I think lots of patients are not diagnosed because they don't get gastric emptying scans. Gastric emptying scan is your gold standard, and you can see this is how it looks. Up top left is the normal emptying at 4 hours, 100% is in the small bowel. And on the right is the Gilead gastric emptying. You can see 57% is still in the stomach in this particular case, post gastric emptying. Management includes small multiple meals, low fat diets, because low fat is emptied very slowly. So use low fat diets. And endoscopic management of gastroparesis, what we described was GPOM. We can do Botox injections or pyloric dilation as well. And this is gastric per-oral endoscopic myotomy. And if you look at the data, this is a meta-analysis, 272 patients who had 84% clinical response rate. So the response is less in gastric poem versus esophageal poem, and largely to do with the pathophysiology, is not purely limited to the muscle. And long-term follow-up on these patients had about 80% response. And this is the most recent randomized controlled trial where they used patients with severe and refractory gastroparesis, were randomized to GPOM versus sham procedure. And based on the data, you can see post GPOM, the total GCSI score had gone down in those who underwent GPOM versus sham. And the sham patients, when they got GPOM, they felt there was improvement. So overall confirming the success with gastric poem. And it works very well for different symptoms as well, from nausea, vomiting, fullness, and bloating. And post GPOM, you can see there is an improvement in the diameter. I think my post GPOM endoscopy video is missing. So it showed really nice improvement in the pyloric sphincter. So in a nutshell, this is a stent repositioning with clips can solve some mechanical problems associated with malpositioned stents. Gastroparesis is uncommon, but you require high index of suspicion. GPOM or gastric poem is safe and effective in refractory patients. So thank you. Yeah. Okay.
Hello, Saurabh.
Hi, how are you?
Nicely done. I don't want to ask any clinical question. I want to ask the first case.
Yeah.
A patient who has undergone repeated endoscopies, bleeding every time, patient from Madhya Pradesh, and then coming to you. So how did you manage that patient professionally? The first question they come to ask you, was my first doctor wrong?
Yeah.
So how do you manage them? How do you counsel them? And then the second question they ask is this endoscopy which you are going to advise me, is it going to help me really? Am I going to get result out of this? So that is one point. How do you manage this professionally? Second is, do you, at any point of your time, do you call the first surgeon, first gastroenterologist, this is how I have found out and this is the way I have treated?
Yeah, so it's a good question. Relevant question for us. We do encounter this a few times. So the guy who first did the endoscopy actually sent to me. So that was easy because he himself had sent it to me. So said, why don't you take a look and see? But yeah, we just say that, listen, we are all humans. Things can get missed. So I need to see again. If you want me to treat, then I have to see. Until I see, I can't comment. And, sometimes, different days, different doctors, things can be different. You may find something. But somebody who already had US, and to convince him to get another US can be slightly challenging. But we always try to maintain this, that, listen, we have to try it ourselves and see what we find. So, yeah. Thank you. But yeah, it is a challenge. 3 endoscopies, US, after all this, to again get him to the table. But he could afford. So that made life easier for me. Yeah.
Saurabh, sorry.
Yes, hi. Thank you.
Saurabh, can I make a comment?
Yes, please. Thank you. Yes.
Yeah, no, I think 2 very interesting and challenging cases. And the first one clearly demonstrates your skill, and some beautiful EUS images is so difficult to pick up. But just while going through the history, what you are presenting, my thought was, my first impression was whether we are dealing with it was a classical history of dilephoid lesion. And the area which was slightly abnormal, it didn't look like a submucosal lesion, just a bit of a mucosal changes. There is some abnormality underneath there. Do you think for people who are doing it for the second time probably, where they can't find a bleeder, and then that is the looking at abnormality, very likely to be a dilophoid. Can they go and put an OTSC clip in that area, which has actually revolutionized management in so many ways, even though they have not actually seen the vessel if it's not bleeding. And it's very tricky to pick up a dilophoid lesions. Yours is a very, very rare case as well. The second question was on your second case. How often do you also come across patients who have esophageal dysmotility when they've had stents for cancers? And then that's more challenging to deal with it as well, especially some patients have ingrowth and have another dual stents placed in as well, which makes it much more challenging.
Yeah, thank you. So I think to your first question, which was, the Dolifoid, right? Yeah. So Dolifoid's lesion by definition are abnormal submucosal vessels, right? So in this particular case, this was not the case. It was clearly a vessel which we could track from the splenic vein, and we could see it come, follow a nice course, and then coming right into the stomach, into that protuberance. And it was previously demonstrated that that was the area that there was a little bit of blood coming. So, while we thought maybe this Dolifoid, but then by definition, it would not be Dolifoid. Could it be fixed with OTSC? Correct. Yes, I think so, because that area was not huge, and placement of an OTSC clip would potentially have compressed the vessel enough that you would not have bleeding. But at that point where I'm on EUS and I'm seeing this beautiful vessel, I guess I was tempted to do something more sort of on force on the EUS, just very targeted, rather than putting just an OTSC clip in that instance. Now, as far as
polypoidal mucosal lesion, would it have obstructed to put, because it was quite big polypoidal lesion, the OTSC clip?
No, I think it was looks probably bigger on the endoscopy view. It's a magnified, but it was about 1.3 centimeters or so. So we could have done an OTSC clip as well. But I don't know, I mean, whether it would have succeeded or not. But here I felt I was targeted the lesion, glue trickling down nicely. So far, though, he's done well. So let's see if he does come back, then we can use OTSC also. Yes. And the second thing is esophageal motility. I'm not sure. Most of them with advanced cancer, I guess, I haven't really felt motility being more of an issue. It's more the stent-related issues, tissue and growth, causing all these trouble. I don't know, sir, or anybody else has felt more motility issues in these patients? Not in my experience, at least. Do you feel motility issues in these patients with esophageal stenting? In the esophagus, really, then?
Yeah, actually, basically, most of the times the stent is done as a end stage procedure, and the life of these patients are so limited. Majority of the times, the indications are where the patient has advanced disease. So at least not in my practice that we've seen motility, esophageal motility problems. But I personally think that in this patient, he had a G junction malignancy. So probably it was some involvement of the vagal nerve, which has given rise to his gastroparesis, because he had advanced G junction malignancy when he was diagnosed. In fact, I was the one who initially diagnosed him about 2 years back. And then he had multiple problems.
Yeah. Yes.
Yeah. So I wanna focus on many compliments first of all about your fantastic presentation, and I just wanna focus on the migration of the stent that was presented in the last case, and as a bariatric endoscopy, I had some similar cases, and I treated that with the Apollo Vertige. Okay. And it's fine because you can make a good orientation using the for the distal part and also for the proximal part of the stent. And it could be a good option in your armamentarium as you are so skilled. Probably you can try also that option in the future.
Yeah, no, thank you. Actually, that's a great tool to have. You're right. Just a little bit of cost issues in India and availability issues, but I think we will ensure that it's available at least in our unit.
Yeah,
so
but
that if
Ovesco
ever
is
required,
also
we should have it.
expensive.
Yes, no, absolutely.
Yeah.
Thank you. Thank you.
Saurabh sir,
Yes, hi, Ron. Yes.
very excellent presentation. About the G poem, second case, about the G poem, if the patient having recurrence of the symptom after 2 years of the G poem, what is your next management?
So the recurrence of symptoms after G-POEM can one be due to if there is now this, if it's a diabetic patient, the symptoms can recur because of small bowel dysmotility that these patients can have, because diabetic patients can have neuropathy and small bowel dysmotility. So you have to understand if what's the cause, whether it's bacterial overgrowth or if it's truly a pylorospasm and gastroparesis induced. Now, the second thing is before we consider any form of therapy, now obviously assuming that you're giving PPI and prokinetics, before we consider any form of therapy, you want to make sure that the pylorus is actually, contracted or not opening now. Because any pyloric directed therapy will only make sense if it's now again like esophageal poem, there's recurrence of achalasia, something of those lines. But otherwise, if that's not the case, then your options are really, really very limited. Because if it's not pylorus directed, it's such a bad pathophysiology of the patient with the antrum involved and the gastric fundus involved, then you don't really have many options beyond IV erythromycin, PPI prokinetics, etc. And I guess ultimately like PEG tubes, I think that is really the ultimate end stage, what you would do.
Thank you, sir.
Okay, thank you.
So yes, we concluded our 117th MIDAS clinical meet. We really thanks our online chairperson, Dr. Shisha, mind if I pronounce you wrongly, Dr. Salvatore and Dr. Raju Mahule for attending this session. I really thanks our offline chairperson, Dr. Abhijit Deshmukh sir, Dr. Rachit Agrawal sir, Dr. Samir Patil sir, Dr. Ashwini ma'am, and Dr. Prashant sir for attending and chairing the session. I really thanks Team Abort, and really thanks all our prestigious speaker, Mukevar sir, Saurabh sir, and also Team Abort for organizing such a nice team. I really welcome all for now cocktails and dinner. Thank you. Thank you.
Thank you, sir.